Hello and welcome to this live Q&A session. My name is Matt Bodman, and for those of you who don't know me, I am the organizer of this ACL Study Day project that we've been working on for the past couple of years. I am here live in beautiful Auburn, California. If you've never been to Auburn, I would highly recommend it. It's the endurance capital of the world. It's the site of the Western States 100-mile foot race. You should come hang out with me, and I'm vaccinated, so that's good. So like I said, this project's been going on for a couple of years now, and it's very exciting to watch it develop. I've been really lucky to be able to partner with such amazing educators. And for those of you who don't know, we started this in 2019 with a live course at UCLA. Dusty was part of that. Last year, we canceled the event, but we were able to come together and bring a course called Home Sessions. That's with Claire Ardern, Rich Willie, and Dustin Grooms. And that was a really great online course. And our newest course is called Evidence and Practice, and that's coming out May 22nd. It's going to be all online. It's going to be very comprehensive. I would encourage everyone out there, if you haven't already, to check out the agenda. It's found on this webpage. And I think the cool thing about this course is that it's pay what you can. So we really want this information out there. So trying to be very flexible with that. And so this blog series is another aspect of education that we're exploring here. And so we're really excited to put out Dusty and Lindsay's new blog. I really hope you got a chance to read it. And I think the best part about this is that not only do you get a chance to read it, but then you get to talk to the authors of this great blog post. And so that's what we're doing here today. So I'm going to bring up our two educators, Lindsay and Dusty, we're gonna do this a little differently. I'm gonna let them introduce each other, so you can get a chance to hear about what they're about from each other. So go ahead.
Great. Do I get to go first?
Yeah, I want to hear all the nice things that you say about me, so I can gauge how nice I speak about you.
Very good. So the bar is set. All right, so I've known Lindsay since 2008, 2007. So we did our master's together at the University of Virginia in kinesiology, and then we both worked for a little bit, and then in the real world, but very short stint in the real world. So all you real clinicians out there, we have a lot of respect for you. And then she did her PhD at the University of Michigan, and I did my PhD at the Ohio State University, and we had similar timelines. And she studied mostly muscle mechanics, muscle morphology, muscle responses to injury and training. And then she went on to do a very prestigious postdoc at the University of Kentucky with Tim Butterfield. And then after that, we both hit the academic job market at the same time, and we got our planes got to cross, going all over the country interviewing, hoping to find a job. And Lindsay ended up at UConn for a few years as an assistant professor. Was very successful, got an NIH-K award, which is a career award, which is very prestigious, and that means the NIH thinks she's a valuable scientist enough that they're going to invest in her career and invest in her research line. Are you getting feedback, Matt? Like an echo?
Yeah, just a little bit.
Okay, I was just wondering. Maybe Lindsay, mute if you're not speaking, maybe. Let's see if that's better. Maybe not, I don't know. I guess you want me just keep going?
Yeah, let's just.
Okay. All right. So she's at UConn for a few years, and she's doing very well. And then, of course, the great University of Michigan snaps her up again, and that is where she is currently. And now she is continuing to explore how muscle changes after injury. And she's one of the few scientists that runs an animal model lab and a human model lab. This is very rare. It's very difficult. One model is plenty for most scientists. Lindsay does 2 models. So this is extremely impressive. So we're very fortunate to have Lindsay joining us today, and I look forward to this discussion with her.
And I heard on Twitter that she's the GOAT, the greatest of all time. which I think is pretty cool.
On Twitter, which is true.
Yeah.
For that very succinct introduction. Yeah, so Dusty and I spent some time together as master students at the University of Virginia, and it's amazing to find a collaborator that early in your career. And we, as you said, we sort of have been marching through our academic milestones at similar times. Dusty took off from Ohio State and ended up at Ohio University, where he's really made some very big waves. Dustin's been a game changer. He brought like a whole new paradigm to ACL research, where folks really didn't consider the brain at the level and the neuroplasticity at the level at which Dustin has done, and he didn't really let like a new methodology get in his way. He just decided to like learn it and bring it to our field. And it's been an amazing addition, and it's opened up a lot of new questions. And Dustin's really on the forefront of all of that. And he's been very successful with funding from the Department of Defense as well as the NIH. And he's a real leader in the field. And he's also just a generally good guy. So if you ever have the opportunity to grab a beer with him, I would recommend it.
Excellent. That was great. I'll second that. Dusty's a very nice guy. All right, so we're here to answer some questions from the audience, and I've gone through them, and what I think would be helpful would be to kind of go through them, let's go through them sequentially as best we can, and we can keep this as light as we want, but we'll start at the beginning. So, one question that came up is, how strong is the evidence to support these strategies for prevention of injury in healthy individuals? And actually, let me just jump. Sorry, before I do that. So I'm going to post the questions in the chat box for those of you who are attending this, and it'll tag it, it'll timestamp it. So if you kind of scroll through it, maybe if you're going back through it, and it'll jump to that part of the video. Okay, go ahead.
I'll take a stab.
You go first.
Dust, thanks. So I can speak to a lot of the blog that I took sort of a lead in authoring was talking about eccentric exercise and the efficacy of that for the folks after ACL injury. But there's a lot of really good sort of like FIFA 11 information on like eccentric exercise being a good type of routine to incorporate to prevent like things like hamstring injury. So it's been well established to be beneficial in terms of protecting the muscle from strain types of events. And so it's good on that end.
And for the neural control pieces, we actually have a paper in review that looked at people with high injury risk movements. What is their neural activation strategy? And so we've already published data showing that after an injury, people increase neural activity in areas that process visual motor information, and they have increased motor cortex activity. However, for prevention, we actually see a similar phenomenon in those who just move with high injury risk. I'm like hearing myself in my headphones. Sounds weird. Sorry. So what we see is that the neural manifestation for control of movement is similar in those post-injury as it is in maybe those that are at high risk for injury. So a lot of the things we work on post-injury also apply for prevention. So particularly trying to not have an overly cognitive or visual strategy for movement. And so a lot of the strategies we discuss have the same implications for prevention, and I would incorporate them in your normal injury prevention program. And that can be as simple as when you do the FIFA 11, maybe instead of just doing the run to cut maneuver where you have them focus on keeping the knees over their toes, you have some sort of external target or something they respond to, or you add an element of reaction or dual tasking to the program you're already doing. And that might allow you to have a little more efficacy and target some of those neural strategies that contribute to injury risk movement.
So follow-up question on that here. I just recently took the sports metrics course like 2 weeks ago online, and it was we got to hear from Frank Noyes himself, which is pretty cool. He's a big fan of the sports metrics course. I was going to ask you, is it actually that good? So do you have a comment on that? Like he's like, this is better than the FIFA 11. I mean, is there any research to say that one program specifically is better than another?
Do you know off the top of your head, Linz?
I'm not super familiar, unfortunately, with that that new course. So if I am able to download it, maybe and onboard it into my brain and see what the differences are, I could comment on that a little bit better. But unfortunately, I am not up to speed on that.
Yeah, I mean, it's just a basic 6-week jumping program, basically, and it's progressive, and it gets a little bit harder every week. It's solid. It looks great. They're obviously big fans of it. Another thing that came to mind is I remember this. I think it was an editorial like 4 or 5 years ago by Roald Barr, and the title was something like "Why Movement Screens Cannot Predict Injury Risk and Never Will." And so I know you talked, Dusty, about increased movement risk or risky movements pre-injury that manifest look similar to those post-injury. Can you kind of talk about like that, like movement screening, like drop jump testing, that kind of stuff that may give us information or not?
Yeah, so the first one on the sports metrics, I think his program was more targeted for jump landing athletes like basketball, volleyball, handball. And the FIFA is really made for soccer. So the FIFA has like the cutting maneuver and they incorporate the ball a little more. I think his program, I think he does have some data on it, but I haven't looked into the prevention program specifically. I would guess it's probably as efficacious as any other program. But what I would just leave that note on is that the compliance is probably your number one problem. And so whatever program people will do will probably be more beneficial than what they don't do. So I wouldn't worry so much which one you're selecting. Some I think are a little more tailored to sport. So I think the sports metrics might be better if you're trying to do volleyball or basketball. But ultimately, I would just do whatever you can get your athletes to do. And that's the most important piece, because there was a really good systematic review on injury prevention training, and compliance is like the biggest dictator of the effect. And so I would just leave it there. The screening question is a very good one. And that Ronald Barr article is something we journal club like every year in our class, because it really sort of kicks you in how we should probably be thinking. And he makes a lot of good arguments in that paper about why screening tests, especially in our field, are going to struggle, mostly due to their non-binary nature. They have a lot of continuous variance. So if you look at knee abduction moment, it's not a either or. It's not like a yes, that's high, and yes, that's low. It's a continuous measure with high variability. So you have people across this whole spectrum, or this whole bell curve of knee abduction moment. And you're trying to like find a cutoff, but the problem is the cutoff on an isolated movement screen on the DVJ misses a lot of things that contribute to the sport injury event. So you're going to have people have high abduction moment that don't get hurt, and people that have low abduction moment that do get hurt. And so that's one reason why movement screens are very difficult, because they're not designed to be either or phenomena. So like a lot of diagnostic tests in medicine are much better at like either the stain or whatever basic science cell culture you're looking for either shows up or it doesn't. So it's present or it's not. And ACL injury risk movement screen is really not there. And so what I think it can be informative for, like the drop jump or other tests like that, it can just give you a piece. So if injury risk, if you think about all the variance that goes into injury risk, and so say if you could explain 100% of the variance of injury risk, then you can predict every injury. So the drop landing screening probably only explains a portion of that variance, but because we know those movement patterns contribute to injury risk, because you just look at the injury events themselves and they clearly have this valgus collapse sort of mechanism, whether it happens right after. I know there's debate whether they go into valgus after the ACL ruptures from the impact from an anterior shear, but regardless, your neuromuscular control of the joint in a screening test gives you some element of that injury risk variance, but they're never going to be as sensitive as we would probably like, because we just can't simulate everything that happens in sport really well yet, probably. I don't know if you have stuff to add to the screening, Linz.
I just think like in general, like it's tough because a lot of our decisions are like just discrete data points, and people are very complicated, right? And just like one, marker of like peak something, there's a lot that goes into somebody reaching peak knee flexion or whatever it may be. And those factors probably need to be considered too. And it's just difficult to find ways to like incorporate all these things. But I think the research community is sort of charged with doing that, because that's what patients need, because patients are complicated. And, we need more rich sort of data to help sort of drive better decisions and better predictive like injury mechanisms. So I think it falls on like the data kind of being gappy.
Yeah. So more like we can get close or have an idea or make some predictions, but there's no yes or no answer. Okay, great. So next question. So athlete gets injured, and then let's say we can get their knee quiet and they're going to do surgery. Do these high load eccentric exercises or reduced attention exercises have a role in the prehab process and in improving post-op outcomes?
You go ahead, Lynn.
So I think one of the kind of core things that came out in our blog was sort of not realizing, avoiding certain things because there's like a fear associated with it, but like there's an unintended consequence that's associated with like the avoidance of like eccentric. So we talked, about like the utilization of open chain exercises. And what I would say to those things is that your muscle is pretty sick after an ACL injury. There's a lot of different factors that are going on that make muscle health difficult to maintain, whether it be neural or like more morphological or some sort of inflammatory response. So really you need to onboard many different types of therapies to like attenuate all of those other factors that are making sort of muscle regrowth or maintenance of muscle so difficult. And I think just the standard prescriptive approach is generally just to kind of, concentrically based exercises where muscle shortening is sort of more stressed. But I think we have some basic data, as does others, to suggest that lengthening your muscle actually does some pretty beneficial things to your body. It's not harmful. And those might be things to consider in the case when those pathways are essentially knocked down. So I do think it would serve a role in prehab. I don't think that it would be dangerous. I think it would be advantageous.
And for the attentional strategy piece, I would encourage you to try to not let them look at their knee as much as you possibly can. Some of our data right now that more people like further away from injury, it seems like it just gets worse, this like compensation that people engage in. We haven't figured out exactly if it's beneficial, like if it's preserving function or if it's a response to inadequate function. My doctoral student, Cody Chris, he just defended a dissertation and he found that people that have high lingual gyrus activity, which is responsible for this sort of cross-modal integrating where you are proprioceptively with where you think you are visual spatially. And so it's trying to match where your eyes tell you are and where your proprioceptions tell you are. And he found that people that were the weakest, they adopted that strategy, that neural strategy the most. So they had the highest lingual gyrus activity. So I think if you can preserve, like use some of the stuff Lindsay's working on and preserve muscle strength as early as you possibly can, you could probably avoid all the stuff in the second half of the blog and not have to worry about it. So if you could find a way to just restore muscle strength of the quad, all of my research career probably won't matter. So me and Lindsay are in a race where if she figures out the link to fix that problem, then I can just go sit on a beach and not do anything the rest of my life. So
I think there's many domino effects. There's many domino effects that happen and they become cumulative, and it just becomes really difficult to deal with once the cat is out of the bag, I think is the saying or whatever, but it's tough.
Yeah, that's a good way. That is a much simpler way to think about it. So the more prehab you can do and employ these strategies, the better you'll set yourself up. Because the longer they go with it, so every day they go with this like overly cognitive or visual strategy, or they have quad weakness, then you're allowing their nervous system to compensate or accommodate to this new normal for them. And it's just going to be way harder later on. So you might as well try to avoid it if at all possible.
Would you suggest early eccentrics or NMES or both?
I'll take that. I think that your muscle needs to be stimulated, period. And there's a lot of different factors that are going on that make it very difficult to actively engage. So NMES and eccentric exercise work by very different mechanisms. Eccentric exercise works by putting mechanical tension on your muscle and activating it that way. It's beneficial in terms of growing muscle and stimulating the nervous system in a different way. NMES just kind of goes to the end of the problem, where the idea is that your nerves and your muscles are not communicating anymore, and so you're going to force them to communicate via exogenous stimulation. I think there's pretty clear data that neural inhibition is a problem and muscle atrophy is a problem. And I think if you can use different types of therapies that can attack any of those pathways, you should use it. And so to answer that question, yeah, I think it would be a good idea to use those things early and often.
Well, then I'll jump ahead here because I had this down a little lower, but we should talk about blood flow restriction training. Is that in a similar vein of like anything that may help?
Dusty, do you want me to take that, or?
I just have probably a small comment for it. It seems like, I know there's a lot of excitement over the intervention, and there are some people working on it, do some really high quality research for it. Probably one of the best papers I saw, it was in an aging population, and they were one of the problems with blood flow restriction. I think some of the research is they'll do like the same load or the same reps or intensity, and then they just add blood flow restriction. So intuitively you would think, well, that's good because you're comparing it to the exact same load, same like stimulus. And then blood flow restriction has a slightly bigger, usually a little more beneficial effect. But this one paper, they had people do reps to failure, and they showed that if you just go to failure, blood flow restriction gives you no added benefit. But you hit failure earlier with blood flow restriction. So there's this idea that if you don't want to do as many reps or you don't want to go as high a load, then it can be beneficial. But I thought that study was pretty elegant. It was in an elderly population that had some sarcopenia-like issues that were weak. But if you're not in a situation where you can't just train to failure, then it might not be worth doing. But if you're in a situation like ACL injury where you can't go to failure, can't go high load, then it could be beneficial. I don't know if you have more thoughts.
I think it's a cool idea. I think the jury's out on like whether it. I think it's really new still, and I think that different high quality places are trying it and trying to see whether or not it has efficacy, but everybody's trying it with a different twist. And so it's very difficult to like compare these programs head to head of like, why one group was successful versus another, because there's so many little twists and degrees of freedom that people have like impermeated into these studies that it's like kind of challenging to compare them head to head. I think it's an interesting thing. I think the thing I like about blood flow restriction therapy is theoretically you should be able to train at a lower intensity and get a better result. And when you're with a population that cannot train at a high intensity, it's an attractive thing to think about. But I don't think that we have robust enough evidence yet in the ACL literature to say, good or bad. More to come, I think.
All right. Okay. So the next question is the quadriceps unique? Do we get inhibition in the hamstrings or other muscles? And then also, is this an ACL specific problem, or do other musculoskeletal injuries give you similar effects after?
So this was I saw this question on Twitter, and hopefully, I don't know if the person was able to make it. I know they were on the West Coast, and they said they might not, but it's because it is a bit of a longer response than you might do over Twitter. So I guess other muscles, we know it happens at the ankle, shoulder, and the spine. So Hodges has shown for a long time that the transabdominal multifidus, they have an inhibition with low back pain. Philip McClure, he's at Arcadia. I think he's done the studies in the shoulder for like infraspinatus or one of the rotator cuff muscles get inhibited with shoulder pain. Maybe a rotator cuff tear, I'm not sure, but it does seem to occur there. Then the ankle, we know the soleus and the fibularis longus are inhibited, at least the spinal reflex excitability is lower for ankle sprain. The knee is an interesting one. It probably has most work, and the person who posted it was right. We see most of it in the quadriceps, and that's somewhat due to it's easier to test, like access to the neural innervation of the hamstring is a little harder, doing maximum contractions, and the superimposed burst technique is harder in the hamstrings, and then eliciting an isolated hamstring contraction with an H reflex technique is tough because the nerve that innervates it isn't really superficial. So there's a lot of complicated neurophysiological reasons why the hamstring isn't looked at as often. But there was a really elegant study by, you probably remember this one, I think it's Hopkins, where he showed that as you do an injection, like a knee joint injection and you give effusion, the quadriceps shuts down, but the soleus kicks up, right? And there's this interesting idea where through evolution or how we were created, whichever you prefer, if you had an injury to the joint or you get joint effusion, then the muscles that directly load that joint will probably shut down to preserve the joint's integrity. So you hurt your knee or you have fusion in the knee, the quadriceps shuts down. And then the soleus comes on more because you're trying to preserve function. So you still have to like run away from the lion or whatever, right? And so if you lose the ACL, you still have to have some function. So the soleus may help you with closed chain knee extension or gait. And there's actually a couple really cool modeling studies that shows if the quad's inhibited, then if you want to maintain gait mechanics, you increase glute max and soleus activity. And that is reflected in the neural literature from Hopkins paper from many years ago. The hamstrings are a bit unique. Their data is sort of mixed. So we have this hamstring reflex arc where in surgery, if I like yank on your ACL, then you'll see a hamstring reflex about anywhere from like 80 to 120 milliseconds later. And so that makes you think, well, okay, so there's this connection. So you'd think if the ACL is gone, the hamstring is going to maybe shut down, maybe because it won't have that impulse to contract anymore. And you kind of see two paths. Carol Courtney had a series of really cool papers where she looked at copers and non-copers. And the people who were able to preserve their function that did the best, that were the copers, they had much earlier hamstring activation for balance and for gait. People who kind of did poorly, they didn't have that. And so in some people, you become hyper excitable or the reflex like kicks up. She also did this flexor withdrawal reflex where people with ACL, their hamstrings actually might come on earlier, but it's not like a universal thing because the people who do poorly, they don't have that response. And the second part of it is I think the hamstrings don't get the muscle weakness to the degree that the quads do. They don't seem to just go to total crap. And it's probably because they don't get this massive inhibition, because since the hamstrings are meant to resist anterior tibial translation and protect the knee, whereas the quads are meant to just shear the crap out of it and load it up. So you're probably having this neural response, but the hamstrings are variable. And I know there's some people working on Grant Norte and Dave Sherman at Toledo are trying to figure out how to do some hamstring stuff. But I think it's a very interesting area in that balance, and hopefully more people could examine it. What do you think, Linz?
I think that was a very well stated review of what we know so far. I think the only thing I would add is like joints that are like ligament dependent for stability generally do have inhibition if they get injured. So ankles, knees, shoulders, joints that are more like bony, like the hip, you know, and like you don't see it there as much. So like ligament dependent joints, when the ligament goes, you see signs of all of the things that Dustin just explained.
Well, that's super cool. Okay. All right. Next question here. What's the mechanism of improvements in muscle inhibition with eccentric exercises? Why does it help?
Well, there's several. Eccentric exercise is able to do some cool things in terms of, muscle's built, the foundational building block of muscle, it's called a sarcomere. It's kind of like a little Lego, I guess you could say. And the way that your Legos are arranged are a big deal in terms of determining your functionality. And the cool thing about eccentric contractions is that when your muscle lengthens, those sarcomeres, those individual Legos, also lengthen and spread apart. And there's unique components on the middle of a sarcomere that when you lengthen it, it opens up a gating mechanism that helps promote protein synthesis that is not available to you if you do a shortening contraction and your sarcomere becomes more compressed. So to restate that, if your sarcomere opens up during a lengthening contraction, there are unique protein synthesis pathways that become available to you that are not available to you if your muscle is shortening. So there's something special about mechanically tensioning the muscle that helps promote protein. There's other protein synthesis. There's other data to show that like the stem cells of muscle, satellite cells, they have a tendency to be more proliferated, more active after a bout of eccentric exercise. And so having more satellite cells around, having them be more active is always considered to be a more beneficial thing. So muscle cells that help with growth and regeneration become more active. The muscle by mechanical tension can grow muscle better in a unique way. And then there's also neural avenues by which I think eccentric contractions work and allow you to achieve a muscle contraction that maybe then allows you to engage in exercise better, then that can also promote sort of muscle growth. So that's kind of like a very glossy overview of, I think there's a number of different things that are special about lengthening exercises that enable you to grow muscle in a different, unique way.
Are there any, that's great. I didn't know any of that. Are there any neural mechanisms with eccentric exercise, Dusty?
Yeah. It seems to generate more neural activity in general. So there's some like conflicting evidence for it based on the extremity, but it does seem to be more like neurologically taxing. So that can be helpful if you're trying to get more neural drive to the muscle. And Lindsay and I did a small study. We only had a couple subjects in it, where we had people with ACL injury. And what we've shown previously is that if you do just the primarily concentric contraction of the quads, we see the motor cortex has to activate a lot more in the ACL patients. And we think that's because the muscle's inhibited, so you have to overcome the inhibition. You got to have much more neural drive from the brain. But if they engage in eccentric contraction, we actually see in those patients that a couple patients, it was a small sample, it's only 2 ACLs, but they actually decreased their motor cortex activity during the eccentric contraction. They increased cerebellar activity and sort of your automatic control activity. So that can be really beneficial because normally we see after ACL injury a trade-off where you decrease subcortical cerebellar activity and increase cortical, which makes sense if you're like thinking about your knee all the time and you just had this traumatic injury and a lot of pain, you're doing a lot of rehab and you're really focused on it. You would exchange this sort of subcortical automatic control for a cortically driven conscious control. But the eccentric contraction seems to reverse that to an extent. We think it has to do with an eccentric contraction is your primary like motor error correcting mechanism. So in a lot of the motor control literature, if you're like doing a reaching task or any sort of precision movement task, if you overshoot, it's an eccentric contraction that saves you, right? Because you're trying to slow it down. Same thing happens with injuries. If you make a bad step, and say if you're going off a curb or you hit a place kind of awkward and your like ankle starts to roll, it's an eccentric contraction that saves your ankle sprain from the fibularis. Or if you land really stiff, it's an eccentric contraction of your quads that save you. And so, in order to make those corrections in a fast enough time to avoid injury, it has to be an automatic control process. You don't look down at your ankle when it's starting to invert and go, oh no, my ankle's going to invert, I need to contract the perineals. That's not how you would just strain your ankle constantly. But all of you probably had this experience where you're walking or you hit a curve or something and you save your ankle, or maybe you stumble a little bit, but you're able to make some sort of motor correction. And that's all subcortically, mostly cerebellar reflex driven. And the eccentric contractions seem to increase that neural activity, which may save you or help you down the line.
Cool. So there's like a capacity component to the muscle itself can handle the loads, and then there's a control component as well. Awesome.
Exactly.
All right. Next question: is there a predictable dose-response relationship with these methods of training?
Do you want me to take a stab at that, Dust, or do you want to?
Yeah, you go ahead.
Actually, Dustin, do you have those slides I gave you?
Yeah, you want to use them?
Can you pop the last one up?
Yeah.
With like 1,000 papers on it.
No problem. So while I get that up, I guess the dose response for some of the motor learning stuff, it's pretty high. And so sadly, if you really want to change a motor pattern and have it achieve this autonomous stage of motor control, it can take a lot of reps. There's some data that says like if you want to have a really refined motor pattern that's really responsive, then you can take up to thousands of hours of practice. So it sort of depends on the level of complexity and nuance you want to get. And it also depends if you're trying to restore motor control or trying to learn something new. So some of those factors can play into it, but the bottom line is for a lot of this stuff, it takes more dose than we can probably do in a typical physical therapy visit timeline. And so this is why I would encourage you to try to advance your patients. And you can always test how they're doing with like a quick dual task, like have them do their quad set, then have them do some sort of mental exercise, like working memory where they have to like add numbers that flash on a screen really fast, or you just flash them numbers with your hand. And if they so totally fall apart, then they need more dose of whatever it is. So that's usually like a good check to see how they're doing for some of the cognitive pieces and the cognitive control of movement. You go ahead. Is this the slide you want?
Yeah. So I kind of thought about this question ahead of time, because if I were like in a clinical setting, I would want like someone to tell me, okay, like you're recommending these things, like now tell me like a way to achieve them. And so what I did here, and Matt, I'm happy to share this in another space as well, is I basically collected like 7 different types of papers that have used eccentrics in some format, and those that have had ACL injury and found beneficial results. And so people are different, and they're at different stages of recovery. And so these kind of run the gamut of somebody having like an isokinetic dynamometer, like what could be done there, versus other people just having like knee extension machines, like a typical sort of piece of gym equipment, like what could be done in that setting. So what I tried to do is like provide like a little bit of a potpourri of like, depending on whatever type of equipment you have, here are some solutions for you. What I can say in terms of like some of the work that we've done is like at minimum 12 treatments appears to be like really beneficial. 12 treatments over 2 treatments a week over 6 weeks. I mean, that's not 40 reps at a treatment. Like that's not nuts. And it can be easily incorporated into like a typical sort of, a rehab protocol. And so I don't think it's overly time invasive. What can be tricky about is where the patient is in the rehabilitation continuum and what type of equipment you have at your disposal. So I try to spread the gamut there in terms of like different types of papers that you could use depending on whatever you have at your disposal.
Yeah, that's great. I would, what I can do is I can post that on the blog page.
Yep.
And I can, anyone who's watching this, if you go back to the blog page, I'll make sure there's a hyperlink, and it'll be a downloadable PDF. So if you could just get that to me in a PDF, that'd be great.
Yeah, will do.
All right. Dave has a question. Lindsay, you mentioned that the muscle is metabolically sick. I love that way to think about it. What are your thoughts on supraphysiologic hormone therapy, HGH, myostatin inhibitors, et cetera, in order to artificially preserve muscle until it gets well? The future, or can eccentrics be enough?
Good question.
I think, the thing I like about eccentrics is they're essentially free, right? And like, you just need to incorporate them. I think that muscle is so difficult to regrow after traumatic joint injuries, things like ACL, that we really should be considering like pharmacological interventions. I think the interesting thing is that the more people probe muscle in those that have had ACL injury, the more they realize that, oh, geez, like this system is involved as well, right? And one of the things that's mentioned in this comment is that myostatin, which is a negative regulator of muscle growth, is really upregulated after ACL injury and during the course of ACL reconstruction. So there's been people that have looked at like the therapeutic efficacy of things like HGH. Like these people are going to lose muscle mass. We know they are. Why aren't we giving them different types of interventions in a controlled manner to help them sort of restore it? Because there's really long-term consequences associated with like kind of letting this muscle atrophy out. So I think the more we probe the muscle, the more we learn that more systems are involved. And the idea of utilizing actual like pharmacological interventions, I think makes sense.
More drugs, I knew it.
All right. That was a good answer. Okay. So let's jump ahead a little more clinically. Under some ideal circumstances, when are you using a full arc knee extension with weights heavy enough to bring the quads to fatigue? Like, is there a practical timeline of stages of healing, or maybe if you could sort of walk through that progression?
I think this is like a question more like, because in part of the blog, we had talked about like open chain exercises. So I think this is sort of in line with that. Hey, Dust, do you want to throw slide 2 up? I think
this will lead into the next question about.
Okay, brilliant. And we'll share all these slides with you, Matt, so they can be takeaways. Dust, do you just want to play through it? I think there's like 2 more clicks or something here. Perfect. Okay, so there was like a lot of like questions about the efficacy of eccentrics in our blog, and then also the idea that like we think that it's a good idea for people to be challenging the quad in the way that it's isolated, which means that you need to do it in an open chain. And what we wanted to kind of show here on this slide is that that can be done really safely. So what you're seeing in the table that's in the top left is basically some really fantastic work that was done a while ago now, but it's basically showing that the different types of rehabilitation exercises, open versus closed chain, and the amount of strain that actually induces on the ACL. And, you know, spoiler alert, like not everything's below 5%, even in the open chain. What's been really cool is there's been some data that's been coming out of Duke to show that, like, in vivo, in a human system, when somebody is walking, you strain your ACL up to 12%. So walking during activities of daily living, there's even some jump landing data to show it's in the same realm, like, is much more of a straining event than most of these like typical rehabilitation things that we would prescribe. So what I'm hoping this slide does is like reassure people that like doing open chain activity is actually quite safe. If your patient is walking with normal ambulation, they're probably straining their graft just as much during that activity than they would be during any type of like typical rehab exercise. And then the other thing is like really to like cause any type of damage, you're really having to think about straining like greater than 25%. So you're really going to have to like crank on that knee to really be in sort of like a real danger zone in terms of like graft failure. So I think the question was about like full arc knee extensions. I think that like low intensity stuff, making sure somebody has like good control, their pain is under control, they don't have any major joint effusion, is always something that you want to achieve as a clinician. The closer the knee is to extension, the more the graft is strained. So if you have concerns, starting this person and doing an arc in like the higher degrees of knee flexion would be a safer thing to do in early stages. Make sure they got it under control and then add in sort of those final degrees of range of motion towards extension. But all of this to say that like that's probably very safe to be doing. And if you start off at low intensities and with good sort of clinical markers, yeah, this patient understands, these other conditions are under control. Like this is actually a very helpful thing to rehabilitation. So I hope that kind of addresses maybe some of multiple points.
Yeah. I mean, I think that brings us up. So the very top line right there, I believe that's from the Bainan article, and there was a specific question about that, and that's from the 1995 article. There was 4.4%. Strain, and that was 30 Newton meters, which equates to about 16 pounds. Well, it's actually not that heavy. So they were wondering if that's helping to justify, open chain exercises as being safe.
I think so.
Yeah. Okay. And then the other question is about walking, because biomechanics do get changed after an ACL injury, and this study was done on healthy individuals. Does that translate well over as well?
I think it does do a fairly good job of translating over. There's been some more basic science that's been done with like cadaver like work that's shown that it translates fairly well between healthy and ACL deficient or strained knees. But I think, our science can always be improved, and, including a cohort with an ACL injury would be helpful in sort of like sealing this up. But I think it translates pretty well. I don't think you would expect it to be wildly different.
All right. Excellent. Okay. So there's just kind of some random smattering of questions as well. So we'll kind of just go through them and see if anyone else out there has a question along. So this is a good one for Dusty. Is there a systematized way to structure attention during exercise? And if so, how do you progress it? And measure it, I guess, would be another way.
Sure. So if you're just trying to think about how you're going to modulate attention or engage in like neurocognitive loading, usually what I do you can think of it in like two buckets. So what are you going to have them focus on? And then are you going to have them engage in some sort of online cognitive task during the exercise you want to do? And so for the focus part, like where are you going to focus their attention? So I think initially if someone can't do the motor task, if they can't contract their quad, well, then you have to let them compensate to a degree by using some attention and some vision and some cognition to try to generate a quad contraction. Because as we talked about before, if you don't get that back, then everything else we do is kind of like worthless. So I will usually encourage clinicians and the ACL patients that I still see, or usually will encourage them to go ahead and don't throw out everything you already know about instructing your patients and getting them to do their exercises. I just encourage you to progress out of it as fast as you possibly can. So once they can do it with some focus, now try to have their attention be on something in the environment. So a lot of times it's called external focus of attention, but external focus is really just meant to be your attention is on like the outcome of the movement and not so much your joints. And in rehab, though, that's hard because a lot of times the outcome of the movement is like quality of the movement. Whereas in a lot of motor learning contexts, the outcome is like, did you make the basket? And so that's a little bit of a difficulty in translating some of the motor learning literature to rehabilitation. So to do that for the simple quad exercise, again, you could just put a target in the air like a bar, or put a laser beam on their shank and have them try to hit a target on the wall. You can be extremely creative with what you're trying to have them do and have them hit their tibia to a target, or as they compress down into the table, if you're having them do like more of the short arc quad or the terminal knee extension, then you can be creative with giving them feedback in different ways. You could put a blood pressure cuff under their knee and have them try to compress it and see the pressure go up on their cuff. So you're trying to just make their visual attention away from the joint, put it anywhere you can, be as creative as you possibly can. And then so that's where you just direct their attention. You try to move them away from internal as fast as you can. And you progress it just like you do on everything else. So I get this question a lot, and really, everyone's a clinician, and a clinician is meant to make assessments and decisions in the moment. So if we were all just technicians, then I would just give you a checklist, you would just do it and you would just follow it. But for everything you do, you're already engaged in this progressive mindset, right? You're always looking to add resistance or add a rep or advance the exercise. So this is the exact same way you should think about it. I'm trying to advance what they're focused on or what their attention is as fast as you can and keep pushing them to have more attention in the world. So after they can do the exercise with external focus, what we'll tend to add then is add some sort of working memory component or online cognition. And so that could mean very simply, if you, for instance, if you're trying to do two exercises, like they could do a lunge or a squat, or you might have them do a weight shift from both legs to their left or their right. And so a good reason why we use like mix with two things, or like a quad set versus a hamstring set, for instance, you can do whatever you want. And we'll flash numbers, and like even might be one exercise and odd might be another. And then as they get better, you might have them flash two numbers, make them do a quick math in their head. And then the answer, even or odd, is that selection. And you can really be extremely creative. I've had one high school GA that advanced people where she had different like colors of construction paper taped to her clinic, and she would like flash a light at them, and each color meant like a different exercise that they had to execute. Like people go crazy with their creativity. What I use often is I'll use a PowerPoint slide deck that just plays numbers or additions or colors or whatever I want, and just set it to auto time every like 3 seconds and flip. And I'll make it like for 100 slides, and then I'll just turn it on, and they do their exercises while they're focused on that. And they have to memorize the numbers or do the math or whatever it is. And the progression is usually simple reaction. So like just make them respond to you. So it could be just like, don't do the exercise and go, do the exercise and stop. Extremely simple. So we can consider that like one-step processing. Then as they get better, then you'll be a two-step processing. I have to convert a number, an even or odd or whatever you get as creative as you want. You do like prime numbers mean something, if you're working at MIT, maybe you got really smart people. But then, so two-step processing means they have to do some sort of chunked process, and then they execute the movement. And then you could do what's called like incongruent processing, which is similar to like a Stroop test where you have some sort of inhibitory response. So this could be, for instance, say you're doing like a side shuffle or some sort of agility test, or they have to make a decision whether they're going to load their left or their right leg from like a weight shift exercise or whatever it is you're doing. It works really well with sides. At first, you would just say left or right, and then you would associate odd with left and even with right. And then you might say, then you flip it and you do the reverse. And so you make them go, oh, left doesn't mean left actually means right. And you make them think about it. So now you're engaged in what's like a interference task. So usually it's like internal to external as fast as you can, single step reactive processing, and then one step processing, and then some sort of interference is usually what we found to be the best like progression.
That was excellent. Where does inhibition figure into that? Like squat on the green light, don't squat on the red light.
So like you mean if your like muscles inhibited, how are they going to
No. I mean, like you're you basically you're doing some reactive stuff, and so you have your PowerPoint going, and you say, okay, the green light flashes, you do a squat. Green light flashes, you do a squat. Red light flashes, you have to stop your movement.
So I think so I think you could have a couple avenues for it. So I'm more thinking like if your quad's inhibited, would that affect the exercise? So kind of going towards, are you thinking more towards like what Eric Mira talked about, like where you make them do an exercise in the presence of quad inhibition?
No, I think we're getting our inhibitions mixed up here. I'm sort of thinking like, the waitress says, hands you your food and they say, enjoy your meal, and you have to stop yourself from saying, oh, you too. You know what I'm saying? Like that kind of
response inhibition.
Yeah, but with response inhibition, but with movement, maybe not with like blurting out stupid stuff.
I think actually response inhibition might be one of the best things you can do. And we incorporate a lot of that in our return to play tests, because we see response inhibition, or like your ability to break or prevent a movement, seems to be knocked down some in people who have musculoskeletal injury. Shields at Iowa, he had a great series of studies like 15 years ago where he looked at this response inhibition when someone's trying to do a squat, like you talked about, Matt, and then you get a quick like break where like you mechanically can't do it. So they had like a device that stopped you, and they looked at your recovery, and people with ACL injury, their recovery from the inhibition, from the response, like the stop response, it took them longer, and they had to activate their muscles to a lot more because they weren't able to like deal with the inhibitory or like that stopping the movement. They struggled to do it once they were set doing a movement. And so we incorporate a lot with the return to play test, the response inhibition, but I would treat it as the same as the interference task. It's like your third level of progression. And some exercises lend themselves better to response inhibition, where you have go, no-go colors or go, no-go signals. And some lend themselves better to like an interference task, where one signal you accommodate to that meaning something, then you change it, and then you have an interference effect. So I would put it at that like third level. I think that's great. Sorry for mixing up with muscle.
No, that's okay. Yeah, the waitress analogy worked. Does it carry over? Will I be better at wishing the waitress a good meal too?
Potentially. Some of the neurocognitive components do have pretty broad generalizability to them. So potentially. I don't make you do promises though, Matt.
Okay. Lindsay, does flywheel training provide an effective eccentric overload?
Well, I think this is a very sort of interesting new sort of way to train that's on the market. And I think it's interesting. I think it's clinically applicable, but whether or not it causes like a big enough overload, I myself don't know. And I don't think there's a ton of literature out on it yet. What I have been able to sort of glean is that like there's a bit of a learning effect, and relative to like maybe other types of eccentric actions that are a little bit easier to grasp. The learning effect is a little bit more difficult potentially with this type of exercise, and so people don't overload quite as well. But I think it's interesting to think about. I can't say if it's. I'm uncertain at this point in time if it's actually effective enough at overloading.
Because part of the thing is that you sort of produce your own load by you rate a force on a heavy wheel, and then it gives it back to you.
Right.
So it's kind of dependent on what you can give it in the beginning.
I think it's a cool concept, undoubtedly. And I think it's very applicable and like low cost relative to a lot of other things. So I really do like it. I haven't been able to like get my own hands on one yet and kind of like really see it relative to like other types of stimulus. And I don't see as much data on it quite yet.
Yeah. Well, if anyone from Eccentrics is watching, Lindsay would like a K-box. Me too. I would like one too. Okay, Dusty, should we be measuring postural sway in the clinic? And if so, how? How should we do it?
It's a good question. So postural sway, I don't know if there's a lot of good data to say that it leads to like re-injury risk. It does seem like we have postural deficits in people, especially if you perturbate them with eyes closed or their visual conditions. But a key to that is if you're going to do it, the knee has to be bent. So if you allow their knee to be straight, people can just use a hip or ankle strategy and the knee's not really taxed in ACL injury. So if you're interested in returning someone's postural stability, make sure you do test them with the knee bent about 30 degrees at least. And then that way you'll at least force something of a knee strategy to be influence postural sway. And I would definitely measure it under different visual conditions. So we use sometimes stroboscopic glasses, these glasses that just shutter. There's a few $100s. They're not too expensive. There's a few companies that make them. And those can be good because you can dictate the rate of visual feedback and you can have it be very severe, closer to eyes closed or a little less. So it's a good way to progress people. If you do use them though, you have to have some sort of external target in the world that they attend to. If you just put it on people, it tends to not have as big an effect, which kind of makes sense. If you could do the task with your eyes closed, it probably won't help you to wear strobes if you could do it eyes closed. But it does seem like eyes closed and under different visual conditions or cognitive conditions, ACL people do have a little worse postural stability. So this leads to, like, how do you want to test it? So there are a few methods. You have the clinical best test or the balanced error scoring system, which is like a clinician observation scale, just checking errors, like their hands come off their hips, they put their foot down. Not super sensitive, probably not your best option if you wanted a really good quantitative metric. There is like the Wii balance boards for a couple $100 that you can stand on and give you good data there. The Sway app, I know that was on a smartphone. People held it on their chest. That was getting some press a few years ago for concussion, but I haven't really seen anything with it in a few years. But it tried to measure like accelerations of the phone when you held it to see how much, how good your stability was. But I think it might not be super sensitive because I think a lot of people can maintain a stable trunk, but they may have corrections elsewhere that the phone misses. So that might be why, or it could be out there still and I just haven't seen it. I'm not really sure. I know Burtech is actually working on a device to bring balance as like the 6th vital sign or 7th vital sign after gait or something. And they got a pretty good NIH grant to put it in a scale. So your physician's scale will have these built-in sensors that are extremely cheap. And it'll give you like a quick test of people's postural stability to look for fall risk. And they have some sort of in-house algorithm that looks kind of promising. I don't know if it'll apply to ACL, their algorithms. I think it's for old people with falls. But I think their technology is supposed to be extremely cheap, like the price of a scale to give you pretty good measures of postural control on a force plate. Less than $100 is what they're shooting for. So their company's just Burtech, BERTEC. If you want to see, I don't know if they have it out yet, but that would be something I would look for if you wanted a cheap option to get postural stability. I'll just make sure to test it under challenging cognitive or visual conditions, or else the ACL people won't have many deficits, especially towards return to play.
Excellent. So, okay, so maybe measure postural sway if it's something that you have in your office. Maybe don't spend thousands of dollars on force plates just to get that data, though.
Yeah, I wouldn't. You could probably use the best as a surrogate. And like if you're really challenging people with some sort of visual cognitive test and you're like just quantum counting errors, then if they're like off the chart, then you're like, oh, well, maybe I need to train them more. Maybe they need a little more work on it. So it can give you a ballpark idea at least.
I saw the Cobalt test recently. I don't know if it's validated, but it's I think they did it as a preseason, pre-concussion testing where they have people on a foam pad on top of a force plate and they give them 2 different visual conditions. One, eyes closed with head turns, like I think it's 30 degrees, and they have them on a metronome. And then they measure their sway. And then the other one is like a VOR suppression. So they hold their thumb out and they move their upper body. Are you familiar with that one?
I've seen it for concussion. I don't know if I've seen it for ACL. Were they saying it could be a good like musculoskeletal prediction too?
No, it was more of a prediction. It was more about like setting a baseline and then retesting with concussions. But to me, it seemed like it could be pretty useful for really any sort of challenge to the lower extremity. So
I think it's more to perturbate like vestibular control and vestibular visual reflexor interaction. And I haven't seen a lot of data that ACLs or musculoskeletal people get much of vestibular reweighting or a shift. But I would definitely think if someone lacked vestibular control, I mean, that would definitely set you up to have maybe higher injury risk or have a poor motor strategy. So I want to count it out.
Interesting. All right. Well, I think that's all the questions I have. I'll check Slido again, see if anyone popped any up there. But that's pretty much it. Anyone who's watching, you have a minute now to put any questions in the chat function. But this has been really cool and valuable and super fun for me. I think this is like the highlight of my day. Yeah. All right, here we go. Ryan, can you talk about objective criteria for return to running?
What do you think, Lindsay?
Well, I think that having like good neuromuscular control, like, the things that you would consider, like, does this look safe? Does this person have the adequate, strength, timing metrics down to be successful with this type of task? Do they walk? Can they walk normally, or without a lot of maladaptations? I think that would be like what I would try to assess clinically first. I'd also try to get a gauge on like psychological readiness for someone to re-engage in sort of a higher demand activity. I'd have to do like a little digging to see if there's anything like truly objective that people have used to say like, okay, you're good to run. In terms of like a true test. But I think I would sort of rely on my like clinical skills to say like, okay, this person's kind of checking all these other boxes. Let's try something a bit more dynamic. And their gait looks, relatively good.
I would just check out the ACL Study Day course by Rich Wiley and see what he says to do. Rich Wiley. Sorry, Rich.
Yeah, I'll second that. Rich goes into a good. He does 2 hours on it, and then like a good Q&A in the ACL Study Day home sessions course. And if you're viewing this on the webpage, it's right there. No, I don't know. Well, I can't. That's sorry. So I think we can wrap up. If anyone wants to drop another question, they can. But we're going to wrap it up here. But I just want to give a plug for this blog series. There's actually 7 more of these coming, which I think is really great. So you guys got to lead us off, and you did a really bang-up job. So the next one is Meredith Shapu and Harjeev Singh. They're going to do some talk about nonlinear lens of rehab. I think it'll be really great. And then later on down the line, we have Mackenzie White. She's going to do a blog for us as well. And so, but I know you both, Meredith, Dusty, and Mackenzie. So I want you to say something nice about them. Could you do that for us?
Yes, of course. I'll take the first stab. Mackenzie White is my PhD student currently. She's amazing. She has an incredible work ethic, and she doesn't take no for an answer, and she's able to incorporate new methods and bring them into our line, and she's been able to sort of break down barriers. And she's been an amazing addition to the lab, and I'm glad she'll be able to share some of those things with you.
Yeah, I'm really looking forward to hers.
Yeah, me too. That sounds really good. Meredith is similarly spectacular. She's a second-year PhD student. Also was a DPT, did her sports residency, very interested in neural control of movement and cognitive implications for controlling movement. And the blog she did with Harjeev was really interesting, even for me, who works in the space every day. So I think it'll be a promising Q&A and a promising webinar. They're going to be the future leaders of our field, and I can't be more excited for both of them. I think the outlook is pretty bright.
Excellent. All right. Well, Dusty, Lindsay, thank you so much for the blog, and thank you for your time tonight. For anyone watching, this is going to stay up for a while, so you can go back and reference this talk, and there may be some stuff in there that you want to re-listen to. Some of it's pretty heavy, but that's great. That's why we're doing it. So, all right. Thanks to everyone watching, and thanks to you, Dusty and Lindsay. Have a great night.
Thank you.
All right. Bye.